very good evening to all the respected doctors present here. I, Dr. Snehal from the USV Medical Team, welcome you all for yet another interesting session in the CME India series, where today we will be speaking upon a very interesting topic, that is combination therapy in type 2 diabetes mellitus. Without much ado, I would now like to hand over to our esteemed moderator for the evening. We have with us Dr. N.K Singh, sir. Over to you, sir. Take it forward with the talk.
Yeah, fine. Good evening to you all, esteemed faculty and our all audience. I think this is our sixth series of the CME India webinar. And today, I am really happy that Dr. Sanjay Kalra agreed to present a very important topic for today's webinar. So first, Snehal, can you give the CV PPT of Dr. KP Singh and Dr. Bijay Patni and Akash? So today Dr. Patni will be joining. He will conclude the session later. So today is a HOD Diabetes Wellness Clinic at Kolkata. You know, I'm not going to tell all details. And then next, Dr. Akash Singh is well known now, invited faculty to many important conferences and senior consultant medicine at Gujarat, Baroda. And he is doing a lot of scientific research works. And great pleasure in welcoming Dr. KP. Hello, you please give the Dr. KP. Next. Yeah, so I think he's Dr. KP Singh from Mohali. He's a director endocrinology, Fortis Hospital, Mohali, recipient of WHO International Diabetic Center Award from Minneapolis and National Builders Award. His biography has been included in 2008 Marquis Who's Who in the World and Oxford International Biographic Center, UK. So he has got 20 years experience as an endocrinologist and published 45 articles in international journals and principal investigator for last 18 years and completed around many phase 3, 25 phase 4 and 5 phase 2 trials. So now I will, he's the today's moderator. So I think now I hand over this stage to Dr. KP Singh to introduce our today's speaker, Dr. Sanjay Kalra, and proceeding. Dr. KP Singh.
Thank you, Dr. N.K Singh, and your webinar series. I am really thankful for the host and the USV, the sponsor. And it is really nice to introduce my colleague, who is a very senior endocrinologist and who is always present in almost all the academic meeting of endocrinology and diabetes. Dr. Sanjay Kalra is well known. He is a consultant and head of the Bharti Hospital in Karnal, Haryana. He is a past president, Endocrine Society of India. He is a past president, South Asian Federation of Endocrine Societies, and past president, Indian Professional Associations. And he is the chairperson of various international societies and very good accommodation. So today he will be speaking on the combination therapy, or you can say the fixed dose combination therapy in diabetes. That is very important, that because the fixed dose combination therapy is very useful in developing countries. It has shown it is cost effective and the compliance is better. And in some FDC, the adverse effects are also seen very less. So Dr. Sanjay Kalra will be speaking, and then we will have discussions after that. And so I invite Dr. Sanjay Kalra to speak on the fixed dose combination therapy in type 2 diabetes. Dr. Sanjay, please.
Thank you, sir. And it's a great opportunity being part of this audience. I'd like to thank everyone who has logged in today to listen to us. It's together that we can make a difference. This word together is very important. No one can make a difference alone. Let's talk about some English words. Once upon a time, we were dependent. We were a colony of another country. That is called dependence. Now, that is not something that any one of us would like to go back to. None of us would want to be a dependent country. So in 1947, we became independent. Now, certainly, independence is a higher ideal above dependence. But even higher than independence is a state known as interdependence. Interdependence means that we are all dependent upon each other for optimal health, for optimal well-being. For example, Dr. N.K Singh sir can do many things alone. But the moment Dr. Bijay Patni and Dr. K.P. Singh join hands with him, he can do much, much more. And there is this Haryanvi proverb which says 1 + 1 is not equal to 2, it is equal to 11. So now you see 3 people here together, 3 seniors, and 1 + 1 + 1 becomes 111. That is the strength of interdependence. Look at it carefully. In our families also, in our society, in our hospitals, we are interdependent upon each other. The moment we understand this concept of interdependence, it becomes easy for us to understand how to manage diabetes. And that's what we'll speak about today. We'll talk about interdependence in diabetes management. And we'll talk about combination therapy. The number of people living with diabetes is increasing worldwide. We all know these figures, and the numbers just keep on going up and up and up every year. In fact, this together, another place where together has come is the Olympic motto. Earlier, it used to be faster, higher, stronger. But a couple of years ago, in their wisdom, the leaders of the Olympic movement changed their motto to faster, higher, stronger, together. So they understand the importance of teamwork in the Olympics, in sportsmanship. Faster, higher, stronger. Of course, we will pray for our athletes, our boys and girls, to bring more and more medals for us back from the Olympics later this year. Neeraj Chopra did us proud a couple of years ago. But if there is one place where we are working faster, higher, stronger, that unfortunately is the diabetes arena. Diabetes is occurring faster at a younger age group. It is occurring stronger, more and more complications, more and more comorbid conditions. And it's moving higher. In spite of all the work that we do, we are just not able to bring our HbA1cs down. This All India data from ICMR India shows us how severe this problem is. Now, this slide is quite complicated, so many numbers, but let me just make it very simple. We know the capital of Qatar, that is Doha, D-O-H-A. So look at Doha and how that helps us remember these numbers. D is for dysglycemia, roughly 25% of adult India. O is for obesity, that's generalized obesity, roughly 30% of adult India. And along with that, you have dyslipidemia again, high LDL, roughly 30%. H is for hypertension, roughly 35%. And A is for abdominal obesity, 40%. So just remember these numbers, 25, 30, 35, 40. That's for dysglycemia, obesity, hypertension, and A is for abdominal obesity. Abdominal obesity, we finished at 40%. Just double that, and that is the ratio of low HDL. That is the percentage of low HDL. It's 80% across the country. So you see that at least 1/3, and if you take low HDL, it becomes 80% of our fellow countrymen and women have dysmetabolism. That is the burden of disease that we face. That is the responsibility that is upon our shoulders. We work hard. We try to improve blood pressure. We try to reduce cholesterol, triglycerides, LDL. We try to maintain weight. Well, some of us try, some of us succeed as well. But if you look at the overall percentage of patients achieving combined HbA1c, ABC target, that is A for HbA1c, B for blood pressure, and C for cholesterol, it is only 7.7%, just 7.7%. We tried to figure out a new way of counting this, of quantifying this. And along with Professor Nitin Kapoor from CMC Vellore and Dr. Suneet Verma, who is a physician from Panchkula, next to Chandigarh, we created something called the kg-A1c product. The kg-A1c product is nothing but BMI multiplied by HbA1c. And we have tried to use that. We have proposed that this year as a means of checking the percentage of people who are able to achieve optimal glucose and weight control. But even when we use the kg-A1c product, the number just remains in single digits, not even 10% of our patients achieve control. Things are slightly better from the glucose window. From the glycemic window point of view, 1/3 of our individuals, of our patients, are able to achieve good control. And one of the reasons why this is so, at least 1/3 are able to achieve control, that's because in India, we have been following these guidelines even before they were created. So like I said, in Haryanvi, 1 + 1 is equal to 11. Similarly, we have been following early combination therapy right from the very beginning. In fact, later on, we'll discuss how India is the capital, is the leader in fixed dose combinations. We have a glorious history behind that. But let's come to current recommendations. And ADA, American Diabetes Association, recommends combination therapy and early combination therapy. They say that you should start combination therapy early in adults living with type 2 diabetes so that you can achieve goals, treatment goals, in a shorter period of time, as fast as possible. The aim of doing is to give a positive or a healthy glycemic legacy or metabolic memory or metabolic karma to our patients. The more rapidly we achieve good glucose control, the longer we will have good glucose control, and that will lead to long-term beneficial outcomes. ADA also mentions that we should use drugs which reduce cardiovascular risk and kidney disease risk, like SGLT2 inhibitors, and we should try to avoid hypoglycemia. Our Indian guidelines, RSSDI, the last guidelines were published 2 years ago. They also say that if the A1C is more than 1.5% above target, you can keep a target of 7 usually, but in some people you may want 6.5. So anyone with a target with an A1C of 8 or 8.5 at baseline should be started on combination therapy. And in case you need to improve heart health, kidney health, or weight health, barrow health, then SGLT2 inhibitor should be considered. So we see that the American and the Indian guidelines speak the same language: early initiation of combination therapy and use an SGLT2 inhibitor if possible, if indicated. In fact, the American Association of Clinical Endocrinologists also says the same. They are a bit more aggressive though, and ACE guidelines actually mention that you should try to bring the A1C down to 6.5 in all people, and even 7.5 A1C is considered severe hyperglycemia. And they say that above 7.5, you should start metformin, and you can start another drug, which can be SGLT2 inhibitor or DPP4 inhibitor. If the A1C is above 9 or is above 8, because see, their target is 6.5 for most people. So if the A1C is more than 1.5% above that, then you can also start triple therapy. That is what ACE says. Do remember that if you have started a particular therapy, it doesn't mean that you have to continue it lifelong. Now, this is speaking to younger people in the audience. When we read Western guidelines, most of the Western guidelines assume that diabetes is a chronic disease. And now they are right. There is no discussion regarding that. Of course, diabetes is a chronic disease. But when they say chronic disease, what they are telling you is that what they assume is that the patient came to our OPD today, to our healthcare system today, on day 1. The patient will continue with us and will gradually keep on worsening with time. That is a natural history. It is part and parcel of human life. With age, we will age. The beta cells will age. There will be gradual worsening of insulin secretory capacity. So we will have more and more insulin deficiency. Insulin resistance, on the other hand, remains relatively stable throughout the natural course of diabetes. But as beta cell function worsens, you will find that the patient will have more and more complications, more and more visits to the hospital, and drug intensification will be required. That is the chronic perspective. This is true. This is correct. But in India, all of us, we have a double burden, a double responsibility on our shoulders. We treat diabetes as a chronic disease, but we also treat diabetes as an acute and as an acute on chronic disease. The number of acute patients that you have in your OPD, whether diabetic foot or frozen shoulder, melanoposthitis, pruritus vulvae, painful peripheral neuropathy, this is what drives the diabetes OPD in most parts of India. So diabetes is an acute illness for the person who is coming to you. So therefore, many times what we have to do, you have to start with intensive therapy. It can be insulin, it can be oral drugs, whatever is required for the patient. So you start with a combination therapy. After the patient's glucotoxicity, lipotoxicity has come down, after that acute illness has been taken care of, the acute illness can be an infection, it can be an inflammation, it can be an invasion, an invasive tumor, it might be iatrogenic, it might be just irritability, that is a psychosocial issue. Once you've taken care of that, you will find that there is de-escalation. So you might wish to start with triple oral therapy and then bring the patient down. This is quite common in Indian practice. Another issue is that our patient presents with multiple comorbid conditions. So some of the comorbid conditions in my OPD include diabetic gastroparesis, helminthiasis, protozoal infection, and lactose intolerance, which is the biggest issue. It is difficult for us to explain to a 70-year-old gentleman that, sir, now you have lactose intolerance. That is the cause of your symptoms. It's not necessarily diabetic gastroparesis. The patient will come back and he will say, I have been drinking 2 kg of milk, 2 liters of milk for the past 70 years. Who are you to tell me that I have lactose intolerance? This is the commonest issue in my state. But still, the point I want to make is that sometimes we struggle with metformin intolerance or metformin pseudo-intolerance. So in such a situation, we might wish to start an FDC, which has a static or single dose. So you keep that, the patient is okay. And you might wish to titrate, down titrate or up titrate the metformin dose as and when the patient requires based upon the patient's GI symptoms. This will remain for a short period of time. Once you de-escalate, you will be able to fix a dose which will last for many months. So let's come back. In the Western world, you have gradual escalation. We also have that gradual escalation, but we also have this situation, intensive therapy at the beginning and then the dose coming down. We have two other patterns of diabetes care seeking behavior. One is called the yo-yo behavior. Yo-yo behavior is patient comes in with severe diabetes, severe hyperglycemia. You fix up the patient and then patient is lost to follow up. And then he will come back very innocently after 2 years. Doctor Sahab, last time I had come with a left foot ulcer and high sugar. That was my disease. Thank you so much. You took care of me. Now I have come back with a new disease. What is the new disease? Now it is right foot ulcer. So please fix me up again. So that is yo-yo phenomenon. In between, the patient is lost to modern medicine. And the fourth one that we have, the fourth pattern is a linear pattern. This again is common in some colleges. So I remember my college where the HOD, such a senior person who can argue with him. So he wrote glibenclamide 5 mg BD to a patient 30 years ago. That was the standard of care. Now, HOD Saab has retired so long ago, but who will argue with the HOD? Nobody. So patient's glucose is 14%, HbA1c is 14%, sugars are 300, 400. Still glibenclamide 5 mg BD is continuing because no SR or JR will dare to argue with the HOD. So that's a linear pattern. Now, in all these patterns, basically, it is a person-centered care that we are speaking about. So keep the patient's attitudes, wishes, and needs in mind while choosing therapy. It's not just about glucose, not just about the risk of ASCVD, but about other things as well. What is it that the patient prefers? What is it that the patient wants? What are the patient's limitations? And what are his or her strengths? But if we are able to work together with the patient, and again, we come back to the word together, that is the most important word, then we can actually improve outcomes. Together means that we speak together with the patient, listen to the patient. Together also means that whatever information we have, suppose I learned something in a meeting from Dr. K.P. Singh or Dr. Bijay or Dr. N.K. Singh, I should be able to translate that into Hindi and Punjabi and Haryanvi or Bhojpuri for my patients. I should be able to explain in simple words. That is the trick of being successful. If you work in a corporate hospital, you may have to translate into English, into Shakespearean English. So be it, then you learn the language. And you may have to learn local dialects. Someone working in Chhattisgarh or Jharkhand, for example, would know at least 20 different types of dialects. And that is what good medicine is about. So you know those dialects. And you explain to your patient that if we take action, we will be able to prevent complications. The action that I'm taking, the drug that we are giving you, this is not for cure of diabetes. It is for prevention of disease. It is for promotion of ill health. So you counsel the patient in such a way that patient feels that you are preventing disease and promoting good health. So madam, let me give you this combination therapy. It will give good glucose control. It will give you durable control, and we will be able to dance at your grandson's wedding. That is the aim of giving the therapy. And you can't do it alone. You need helpers. You need healthcare system to help you. You need the public to help you. We all are there together. And you also need different drugs to help you. If you are able to overcome this therapeutic inertia will also be, I give one tablet to a patient. So patient does not bother about combinations. Patient is bothered about number of tablets, number of injections. So I tell the patient, madam, you had 1 tablet earlier, now we have to give you 3. Patient will get upset. So in the same tablet, I can give a combination therapy. And if I'm able to do that right from the very beginning, we will actually be able to improve long-term outcomes. And we will be able to keep glucose well controlled for at least 2 years extra. And 2 years is a lot of months. It is a lot of days, a lot of weeks. It's not just 2 years of health, of a life, it is 2 years of healthy life that we are getting. And all these are statistically significant. Now, initially, you can give metformin along with any other drug. But you will find that across India, DPP-4 inhibitors are very popular, though they don't get, top billing in the Western guidelines. There are 2 reasons for this. And in both, I would like to commend each and everyone. I would like to thank each and everyone who is logged in with us today. When we are treating patients, we are worried not only about efficacy, but also about safety. When you use a DPP-4 inhibitor, you can use it for a long period of time without having to bother too much about monitoring. You don't have to do too much of renal monitoring, hepatic monitoring, cardiac monitoring. That is why Indian physicians use DPP-4 inhibitors. You don't have to worry about hypoglycemia. That's one reason. And the second reason is actually there is more incretin deficiency in Asians. So multiple studies from our country, from Korea, Taiwan, Japan, show that Asian patients respond better to DPP-4 inhibitors than our Caucasian colleagues. So therefore, DPP-4 inhibitor and metformin are used as a preferential therapy in our part of the world. There is a biochemical or a physiologic rationale for it as well. So not only do you have more durability, you are able to correct more pathophysiologic processes. Now, this concept of pathophysiologic processes, I initially found it very difficult actually to understand. Ominous octet, ab hum thare Haryana ke log, we can't count beyond 5. So how do you count 8 things? So we tried to simplify it. So we divided all the drugs and all the pathophysiologies into 3. All drugs can be classified as either insulin secretagogues. They help the beta cell secrete more insulin, or insulin sensitizers. They are sensitizers. And the third is calorie restriction mimetics. They mimic calorie restriction, either at the level of the gut, like acarbose, voglibose, or at the level of the kidney. How do we explain these 3 to our colleagues in internal medicine? Imagine that you have a fluctuant abscess. How will you treat the abscess? You can use a bacteriostatic antibiotic. Our glucostatic antibiotic is metformin, glucostatic, just for ease of understanding. You can also give a bactericidal antibiotic. Our bactericidal drug is sulfonylurea, insulin secretagogue. But when you give a bactericidal antibiotic for a long period of time, you can get in trouble. Like, all the good bacteria will also die. And then somebody might turn up with the pseudomembranous enterocolitis or something, diarrhea because of antibiotics. So how do you prevent that collateral damage with the secretagogue? With the sulfonylurea, the collateral damage is hypoglycemia here. You can give an indirectly acting secretagogue, which is a DPP-4 inhibitor. DPP-4 inhibitor will finally act upon the beta cell, but indirectly, it will not cause any collateral damage. It will not cause hypoglycemia. So bacteriostatic, metformin, bactericidal, sulfonylurea, and DPP-4 inhibitor both. And the third one is incision and drainage. For fluctuant abscess, the treatment of choice is incision and drainage. How do you do an incision and drainage in diabetes? I mean, you can't go and cut open the patient's skin. So the incision and drainage is done at the level of the gut using acarbose or voglibose, or it is done at the level of the kidney using SGLT2 inhibitor. And this simple concept, 1, 2, 3, it makes it very easy for us to understand now what kind of drug to give what kind of patient. Even simpler than this triple model is something that we use from Indian philosophy, from our national philosophy, and that is the banyan tree. Now, if you read the Bhagavad Gita, I think it is chapter 15, if I am not mistaken, the banyan tree is called the tree of life. And it is so clearly mentioned, the roots go upwards, the branches come down. You read that chapter and you will feel that they are describing diabetes. They are describing the pathophysiology of diabetes. Even when you see how glucosuria was earlier considered a marker of disease, and now it is considered a marker of effect of a drug, of SGLT2 inhibitor. See the way we have changed. And the banyan tree teaches us that roots and branches can all look the same. And that is exactly what happens in diabetes care. So if you look at the banyan tree, you will find that it's a very complex tree, very large, multiple roots, multiple branches. Same for diabetes, multiple pathophysiology, multiple causative factors, multiple complications, comorbid conditions, consequences. Approach it that way. But now look at the positive point. The banyan tree is a tree which offers shade, it offers shelter, it offers succor to weary travelers. So in diabetes care also, we can view that as a banyan tree, and we can use multiple branches like metformin, DPP-4 inhibitor and SGLT2 inhibitors to give safety and shelter to our patient. Metformin, we have already mentioned, is like a glucostatic drug. But if we add DPP-4 inhibitor, we are acting upon the beta cell, insulin, secretagogue, indirectly acting. Not only that, DPP-4 inhibitor also acts upon the alpha cell and increases sensitivity of the alpha cell. Increasing sensitivity of the alpha cell means that the alpha cell gets to know when should I respond, when should I bring out glucagon? Only if there is hypoglycemia. When should I relax? If there is no hypoglycemia, let me relax, let me not bring out any glucagon. And this is called the islet, 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 de-stress, DE, stress hypothesis. The islet de-stress hypothesis says, and this is written, I think, along with Professor Yashdeep Gupta from AIIMS New Delhi, what it suggests is that in type 2 diabetes, the islets are under a lot of stress. Insulin is too much because of insulin resistance, so glucagon becomes too much. Glucagon becomes too much, beta cells work more insulin. So both are always under stress, and koi fayda to ho nahi raha. Both are, just fighting each other. If you're able to de-stress both of them together, alpha and beta, both will relax, both will become healthier. So that is what the DPP-4 inhibitor does. And what the SGLT2 inhibitor does is, it just does that incision and drainage. It takes out all the poison from the kidney, and the body is able to relax. The endothelium, the blood, everything becomes much healthier. And now if we understand this, we don't need to count the ominous octet. Though Dr. DiFronzo is, he's a great teacher, and I've been lucky enough to share the dais with him at multiple platforms. But last couple of weeks, I've been thinking that ominous octet is a very sad kind of a messaging. And this thought came to me just a couple of weeks ago. Now we've begun talking, and again, the co-author is Professor Nitin Kapoor from CMC Vellore, the octagon of opportunity. Let's not view this as ominous omens. Let's view them as opportunities. So see, we have not one, not two, but we have 8 opportunities. How we can handle diabetes, how we can manage diabetes. All these are opportunities for us. Many times my patients will come and tell me, sir, you are just hell-bent upon giving us more drugs, more combinations. Why is that? Then we use the example of Vaishno Devi. She is the leading deity of our part of the country. Dr. N.K Singh is also aware. So we ask our patient, do you believe, do you trust, do you respect Vaishno Devi? And the answer will invariably be yes. How many arms does she have? Kitni bujhaएं hain? 1, 2, 8. The answer is 8. Kitne astra shastra hain unke paas? How many weapons does she have? The answer is 8. So similarly, you tell the story of Vaishno Devi Mata. She, Rakshas went after her. When she was not very comfortable, she went and hid in the Garbh June for 9 months. But when she came out with all weapons blazing, and she defeated that weapon. Why do we, she defeated the Rakshas. Why do we worship her? Because she defeated the demon. The demon here is diabetes. If we are able to manage with 1 or 2 astra shastras, that's fine. If not, we should use combination therapy. And even when you look at Vaishno Devi's hands and what she has, she uses a mixture of education, a mixture of calmness, along with fighting weapons. So that's what we do in the diabetes care arena as well. We use our drugs, and we also use education and counseling. When we counsel our patients, we should be able to tell them that, yes, very confidently, you have uncontrolled diabetes. The issue is only with uncontrolled diabetes, not with diabetes. If we are able to bring your control back to normal, we should be able to give you a healthy and happy life, a long life. And if we use a combination like maybe dapagliflozin and linagliptin, the drug combination is safe, it is effective, it will help you achieve good glucose control, It will also keep your heart safe. It will keep your kidneys safe. In fact, it will improve the health of your heart and kidney. And if we give these together, 1 + 1 is 11. And again, you can use the concept of Vaishno Devi or any other concept which is locally relevant. You will be able to get better outcomes. All this is important because, see, you can write the best possible prescription. Writing is easy. Prescription has a paracrine effect. Let us look at this concept from endocrinology. Prescription means I am sitting next to Dr. Akash Singh. I am the patient. He prescribes a therapy that has an impact on me. But the moment I go away, paracrine means you are impacting the next cell. The moment I go out of the room, now I am impacted by other paracrine factors, by my family, by my society, by the chemist, by so many people. So prescription is paracrine, but education is endocrine. Endocrine means the impact lasts far. It goes far and beyond. So when Dr. Akash educates me and he says, young man, it's nice. Dr. Akash, please call me young man sometimes whenever possible. So when he says, young man, please take this medication. It will help you remain healthy and we have to dance at your grandson's wedding. Something like that. And I have tried to give you a medication which will reduce the number of pills. And there you don't have to worry too much about whether you're taking it before breakfast, before lunch, 5 minutes before, half an hour before. We are bringing flexibility, democracy into your life. Then certainly I will listen. And that education will have an endocrine impact. It will impact me beneficially, and I will take that education back to my family, my community, and I will spread the word. In fact, this actually is the way to build up a practice in chronic care. And this is why also combination therapy and FDCs help. If you're able to bring adherence to an optimal level, HbA1c will automatically become optimal. And the more the number of drugs, the less the adherence, the less the persistence. The lesser the number of pills, the more the adherence. That is proven by evidence and also by experience. That's why FDCs are used. Now, the Western world has begun speaking about FDCs just recently. But have you realized that the first FDCs were created in India? Iron and folic acid, ibuprofen and paracetamol. These are India's contribution to the world. In the diabetes arena, Dr. K.P. Singh sir will agree with me, fenformin and chlorpropamide. This was the first FDC that we had long before the Western world even thought about it. So this is India's contribution. And with FDCs, we are able to make things simpler for our patients and for ourselves as well, actually. Another impact of the SGLT2 plus DPP4 inhibitor, SGLT2 inhibitor plus DPP4 inhibitor combination is that it reduces the risk of genitourinary infections. This is because the DPP4 inhibitor inhibits certain enzymes in the fungal cells and prevents the fungal cells or the yeast cells from growing. So you are able to get better compliance and also more safety. Now, many people speak about infections with SGLT2 inhibitors, and rightfully so. Melanocystitis, pruritus, vulvae are quite common. But a few tips. First of all, do take a history. Anyone with poorly controlled diabetes, ask about genital infection. Secondly, talk about genital hygiene. Many of our men here will use Dettol or Savlon, which actually spoils the mucous membrane, which worsens the mucous membrane. So you have to tell them to wash with water. Many of the postmenopausal women have a chemical irritation, a chemical vaginitis. All pruritus vulvae is not infectious. And certainly all pruritus vulvae is not fungal. It can be trichomonal, it can be bacterial. So therefore, you have to take a history, if possible, examine. And many a times the treatment of the postmenopausal pruritus vulvae or dyspareunia might be just a lubricating gel or a local estrogen cream. Speaking of estrogen gels and local lubrication creams, bring us to complementary therapy. When you are managing diabetes, don't focus only on the number. Look also at the blood pressure, at cholesterol, quality of life, well-being, whatever complaints and concerns the patient has. Do remember to ask the patient, what is your major complaint? What is your main concern? And try to address that. Supposing my patient comes to me and says, I have a pain in my abdomen, and I say, I am the best doctor in the world, I will bring your HbA1c down to 6 without causing hypoglycemia. But for pain abdomen, I forget to give the medicine. Then patient is not going to come back to me. So do remember to treat your patient's complaints and concerns. One complaint and concern that we experience quite frequently in the OPD is weight gain. So when you use SGLT2 inhibitor plus DPP4 inhibitor, you are actually able to reduce weight gain or reduce weight as compared to sulfonylurea-based combinations. So this is also something that is important. And like I said, the KG-A1C product is something that we should be measuring in our patients. DPP4 inhibitor and SGLT2 inhibitor combination are shown by evidence to be statistically significantly better at lowering the weight. Not only that, hypoglycemia is much less with DPP4 inhibitor plus metformin as compared to sulfonylurea. We are all aware of this, and especially during the holy month of Ramadan, when the fasting period is around 12 hours here in North India, hypoglycemia is always a risk. There are good studies on modern sulfonylureas in Ramadan, but now that we have DPP4 inhibitors, we should be using them. Also, CV outcome trials with SGLT2 inhibitors, we have CV benefit. With DPP4 inhibitors, except saxagliptin, we have CV safety. And irrespective of whatever outcomes you look at, you will find that SGLT2 inhibitors improve the CV outcomes across board. DPP4 inhibitors are CV safe and renally beneficial. So if your patient comes and asks you now, doctor, I've got diabetes, what should I do? The answer is don't get upset, don't get worried. Diabetes is not a death sentence, provided we control it. So let's hit early, let's hit hard, let's take inspiration from religion, from philosophy, from the banyan tree, and let's give you a combination which will help bring down your glucose rapidly without causing hypoglycemia. This will be the short-term benefit that you will experience, but the long-term benefit is that we will be able to postpone cardiovascular outcomes, prevent them, and also postpone the final inevitability. And we'll certainly be able to dance together at your grandson's wedding. Thank you.
Very nice to hear your presentation and really great. Learned a lot and really thankful for the very latest scientific discussions. Now the Dr. N.K Singh is going to have for the panel discussion after that.
Yeah, I think now we will first let Dr. Sweta. I think do you have any questions in the chat box?
Yes, yes, sir. Yes, sir. I'm just sending them to you, sir.
You can send in the okay, or send to Dr. KP Singh. I think this was a unique lecture today by Dr. Kalra, where really I have given so much stimulus to me, like the Bhagavad Gita example of banyan tree, and I think with Nitin, Dr. Nitin, I think that concept looks they're going to be hit, that it is not ominous octet, but how the from this is something we are changing from the old India pattern to the new Bharat, and that is working, that we are making new opportunities, not we are some nirasavadi, we are only taking something with hope. So I think with all these organs, with how beautifully he has given the message of combination therapy, that is really, I think, appreciable. Dr. Akash, at this point, would you like to comment?
Actually, there was a slide where there was a major emphasis on the beneficial effects of SGLT2 on patients with the risk factors for ASCVD also. So here, would a GLP-1 receptor agonist be a better option or SGLT2?
Yes, sir. Both are good options. If our main focus is weight loss, then GLP-1RA will be better. If our main focus is cardiovascular disease reduction, then both are equally good. If it is renal, again, both are equally good. If it is reduction in heart failure, then SGLT2 inhibitor will be better. And another thing is that both can be used together. We can use GLP-1RA and SGLT2 inhibitor together as well. But both are good options, sir. Only I think heart failure will be one differentiator, and another differentiator will be the degree of weight loss that is required.
As far as the primary prevention of ASCVD is concerned, what are the recommendations for SGLT2 inhibitors?
the Cardiology Society has actually mentioned that SGLT2 inhibitors should be used at the very onset in people with diabetes. Also, the studies as well as prescribing information from both USA, Europe, and India that says that even in people without diabetes, we can use SGLT2 inhibitors now to reduce the risk of heart failure and to reduce the risk of chronic kidney disease. So all the guidelines are promoting it. In fact, the cardiology guidelines mention it as first-line therapy over and above metformin.
Dr. Kalra, I think you have given a very important message also that if there is early combination of the DP4 inhibitors with SGL2 inhibitors, it has been shown that the incidence of this GTI that decreases. You have tried also give the mechanisms to why it is happening. I think recently with this panel, Dr. Bijay Patni is here and Akash, who have done a genius study, which we are sending for the publication in a week. There was data on the more than 22,000 patients all over India, 45 centers. And this is there are very strong data emerged that this is happening. So I think, Dr. Patni, would you comment on this portion or this part that what is your clinical experience with this combination and GTI issue?
Thank you. At the outset, I would like to thank Dr. Sanjay Kalra. It's always a pleasure hearing him. He mixes the art with the science so well and make the total deliberations in a lucrative way that I always admire that whenever he speaks. Now, in our clinical experiences, a variable stuff, the phenotype really is so much of variability, whether it's the different sexes and all. Whenever we try to combine these two molecules, do not get a uniform kind of outcomes. Now, this is also important in our context because, see, a lot of our patients already have a susceptibility to UTI. And even at the time of history taking, you probably miss out. And when we try to prescribe this combination with the hope that when you combine these two, probably the incidence decreases, but actually doesn't do so because there is a baseline problem which probably we were unable to capture. So the differentiation in the phenotype is variable. So very difficult to really come to some conclusion that this combination as thought about, it should reduce the incidence of GTI. What happens with a single molecule of SGL2, this is not seen uniformly in most of the patients. This is my real world thoughts. I mean, what we see in our clinical practice.
Dr. Kalra, on this point, what you would like to say?
Fully agreed, sir. Every patient is different. And what Dr. Bijay is saying is right. So if you have a patient with a history of frequent, recurrent, refractory, resistant UTI or GTI, it would maybe not a good idea to start SGLT2 inhibitor. Stabilize the patient first. Second is, so many times I have seen the OPD, especially with women. You ask them the first time, do you have any pruritus bulbae? The answer is no, I don't have. Either they are shy or they don't understand what I'm asking, even though I use different locally relevant verbiage, or actually the hyperglycemia is so much that they have neuropathic unawareness. And after a week, when let's say you give insulin, the glucose comes down from 400 to 250. Then they come back and say, yes, now I've developed itching. Earlier also they would have itching, but they wouldn't know. Or they would have dribbling of urine and they wouldn't even be able to smell their urine, that they have soiled their clothes. And after a week, they come and complain when the glucose comes down to 200, 250. So that point is very well taken and we should be aware of this. And that is why we have drugs because, different drugs because there are different pathophysiologies. Similarly, like Dr. Akash said about GLP-1RA, if you have a person with a phenotype that is prone to GI disturbance, the patient says, for the past 1 year, I have been taking proton pump inhibitors, I have gone to 3 different types of doctors for GI symptoms, then maybe GLP-1RA would not be a good drug to start right at the very beginning until you have built the confidence in the patient. So
one point,
yes.
One point made in the genius study which we all did together, duration of SGLT2 therapy, we measured the incidence of UTI, GTI in the first 6 months, in 6 to 12 months, and more than 12 months. And we found that in the first 6 months, the incidence of UTI was much more than 6 to 12 months and more than 12 months. the mechanisms we are trying to understand why early on in the SGLT2 therapy, the incidence of UTI is more. And the answer may be manifold, and one of the postulation may be what Kalra sir has just stated, that patient may be having a neuropathy not coming up with a proper complaints. And second thing is that initially the patient selection may not be proper, leading to more incidence of UTI. And subsequently, once the patient is on continuing on SGLT2, the incidence would subsequently decrease.
Also, sir, the glycemic control will improve when the patient is in your hands. Patient came in with baseline high HbA1c, so she was more prone to infection. And as she remains in your hands, in good hands, the A1c comes down, and therefore the immunity improves and the susceptibility to infection goes down.
I can
These
see
days,
a few
yeah,
questions.
yeah.
I can see a few questions. Because one question was, what is the role of troponin in heart failure? In heart failure, we do the anti-pro-BNP and BNP. No, troponin is for the acute coronary syndrome. So that is the answer. And that at up to what EGFR, SGLT2 can be given, it is usually given more than 30. Because if you give less than 30, it may have the renal effects, renal beneficial effects, but it may not have the glycemic effects. Dr. Kalra, you want to add in that?
Yes, sir. Agreed, sir, with what you said.
Any more questions?
And one thing is that I have seen, because now that SGLT2 inhibitors also giving in patient without diabetes. So I have seen the number of prescriptions that dapagliflozin is given 10 mg BD, and on the top of it, this empagliflozin is also given. So I saw in the last month the 3 patients on 20 mg of dapagliflozin and 25 mg of empagliflozin. So it is the 3 times of the SGLT2 for the patient. So I think this is a misuse of SGLT2. One should understand that what is the maximum dose of SGLT2, and you cannot use the 2. So that is also because you have to educate the physicians. So patient, whatever the prescription has written, the patient will be taking, and that is the prescription from the corporate hospitals. I don't want to mention, but this is the only to the education is very important. And that another question, but whenever you think of heart failure or you think of the primary prevention, secondary prevention of the renal disease, I think SGLT2 is on the top. When ACVD is concerned, then the first primary is the SGLT1 receptors. But the both will be beneficial in both the disease. That is my view. Okay? Any other questions? Please ask Dr. Kalra or Dr. N.K Singh.
Can I?
Yeah.
A very practical question. And a young diabetic with HbA1c of more than desired HbA1c of more than 1.5%. A young patient with no ASCVD or risk factors, a combination therapy of fixed dose combination therapy of DPP4, metformin, and pioglitazone. Now, this particular combination, if the HbA1c is above the target, more than 1.5%, not a dual combination, but a triple combination, going for intensive management right at the start. Do you think this combination is a good combination for such a patient?
Yes, I do use pioglitazone in my practice, and frequently, not as monotherapy, but along with other drugs like you have mentioned. Multiple indications where you will preferentially choose pioglitazone. One is someone with pre-diabetes, whose pre-diabetes status is severe, symptomatic, associated with high spectrum of pre-diabetes. That means there is both impaired fasting and impaired postprandial glucose, or with the susceptibility to cardiovascular disease, because the main aim is to reduce cardiovascular disease, especially susceptibility to stroke. So see all these things, someone with severe pre-diabetes, sustained pre-diabetes, wide spectrum of pre-diabetic values, susceptibility to heart disease, susceptibility to stroke, and also sibling history, a strong family history. In such patients, pioglitazone would be preferentially indicated. Amongst all these, specifically stroke, if you want to reduce the risk of stroke, pioglitazone is a very good drug, much better than the other ones. And third indication is a local indication that we have. Many times a sarpanch will come to me, or a policeman, a traffic policeman, and they will say, Doctor, personality nahi ban rahi, I want to gain weight. So the reason is he is working as sarpanch, but nobody listens to him because he is lighter than all the other men in the village. Or the policeman says, Doctor, my uniform doesn't fit me anymore. And I want to look obese, I want to look big. In such patients also we use pioglitazone. That is their concern and complaint. They want to gain weight for social health. So that is another indication that I have locally. Here we do tell our patients, this is my normal communication style. As long as you are comfortable, that's fine. But the moment that you feel you need to buy new clothes, you need to go to the tailor to get your trousers restitched, please don't go there. Please come back to us. That is an indication that we have climbed the mountain and now we are going to come down. So allow me to reduce the gear, allow me to reduce the accelerator of your medicines. Come back to us instead of going to the tailor. So that is a common sentence which I use in the OPD with bio prescription. The only
I agree with that, Dr. Kalra. Because with the SGLT2, the scientifically it is good, it is better than SGLT2, but the feel good is not there. Patient will be feel happy when you add the pioglitazone. So that body pains and the urinary frequency and uneasiness, because that is seen with the SGLT2, is not seen with the pioglitazone. Patients are happy with the pioglitazone. If patients are not obese, I think pioglitazone is a good drug in the combination therapy.
Like Dr. KP Singh said, sir said about not using two SGLT2 inhibitor together. For pio, I would just like to caution, get your fundus examination done regularly, because proliferative retinopathy, that many times we miss. I also miss, and that is, it's not nice, like if you miss it.
Because macular edema is common with the pioglitazone therapy.
Or pio is contraindicated with macular edema. So we should avoid.
So I think we have one question in the chat box. In patients with frequent episodes of hypoglycemia, which combination to give?
Avoid sulfonylureas, and all the rest can be given. Start with monotherapy. Here you can go safe. Maybe you might want to start with the DPP4 inhibitor first of all, or SGLT2 inhibitor, and then you add the other one. So just go slow. Counsel your patient to take a 3+3 meal pattern, 3 major and 3 minor meals. And also there are other conditions. Patient might have celiac disease that can have both hypo and hyper. Patient might have a GI infection, protozoal helminthic. So rule out all these things. There might be an autoimmune condition. 3 endocrine conditions that you should rule out: hypopituitary, hypothyroid, hypoadrenal in hypoglycemia. And 3 medical conditions that you must rule out, that would be hepatic impairment, renal impairment, and gastrointestinal impairment. GI impairment can be a motility disorder or an absorption disorder. If we think in these terms, then the diagnosis is clear. And before all these, 3 lifestyle related issues that we must rule out. One is erratic dietary pattern. See the word erratic. Aaj kuch, kal kuch, parson kuch aur. So erratic dietary pattern, erratic exercise pattern. One day I am sitting and watching TV the entire day or sleeping. The other day I go to the gym and do 3 hours of exercise. That is erratic. And the third would be erratic beverage consumption. So no comments on Dr. Akash's beverage right now, but erratic beverage consumption. So some increase glucose and others reduce also. My favorite is lassi.
Many companies have brought that combination therapy with the glimepiride and this SGLT2 inhibitors and that DP4 inhibitors. So this hyperglycemia risk will be very much, because SGLT2 is a powerful anti-diabetic drug. Glimepiride in the early phase of diabetes is a very, very powerful drug. So the chances of hypoglycemia will be very much with this combination. Sulfonylurea and SGLT2 along with the metformin and other thing. So this many companies are bringing this fixed dose combination. I think the safety will be a problem with that combination.
This is an irrational combination, by all means.
Yeah.
So I think what is the exact role of this combination, like Lina plus DAPA? Many companies, I think the market is flooded now with this combination. So what is the exact patient subsets where we can start, whether in the initial phase or in the later phase?
If, sir, someone has an HbA1c to begin with of more than 8.5, we can start metformin. That is one tablet, sustained release, plus Lina-DAPA combination. So you can start with triple oral therapy. Especially if you feel that you may have to titrate the metformin dose, it is a good idea to do this. Give the metformin separately and give the Lina-DAPA separately. Lina-DAPA dose will remain the same. Metformin you can take up or down. That is one situation. Another situation is if metformin is not tolerated at all. You've already tried metformin. Glucose is not coming down. Patient is not able to tolerate even 500 milligram OD. We have few patients like that. Then we can give Lina-DAPA without the metformin. Third indication, though I would not recommend that is supposing someone is on sulfonylurea plus metformin and is not doing well. So you're already even giving two drugs. So we say triple oral therapy is allowed. After that, we should shift to insulin. But you can always try 4 drugs. So you continue the metformin sulfonylurea and add Lina-DAPA to it, but that will become 4 oral drugs. Try to avoid that. Many of my prescriptions will have 4 oral drugs. So that is the prescription, the paracrine effect. But the story that is going on behind the scenes, which is not documented, is that we have been speaking to the patient about insulin. Patient didn't agree. So we said, okay, you take this medicine for 15, 20 days, come back to us. And slowly, gradually, we are trying to build up the patient towards accepting insulin. That is the endocrine effect, which is sometimes not visible from many prescriptions.
Fine. So I think we are now at the end of the session. And so before I will take the take-home message from each of you, I think Dr. Patni, this is time to conclude this session today.
Thank you, Dr. N.K. Singh. I think this was a very informative session, particularly on combination therapy and fixed dose combination in particular. We probably tried to evaluate almost all the fixed dose combination and all the patient patterns where these can be given. So having Dr. Sanjay Kalra as the one who is going to educate us, I think nothing better than that. I think most of the delegates must have enjoyed the talk today. And I thank you, Dr. Kalra, sir, and Dr. K.P. Singh, sir, for your informative inputs, and Dr. Akash Singh for giving us some informative backgrounds as well. And thank you, Shweta, as well. So I think it was a good session to be in this particular plan which we have come out with the CME webinars. So over to you and Dr. N.K. Singh, sir.
So I think Dr. K.P. Singh, sir, what's your message will be a take-home message from this combination therapy for our audience?
Yeah, this Lina-DAPA will be very good. It would be very good for cardiac point of view, from the glycemic point of view, from the safety point of view, and from cost-effective point of view. It is very good from safety and efficacy, cardiac and renal effects. Only a little worried that you have to educate the patient for genitourinary hygiene. If you can avoid that genital and urinary tract infections, then that will be a very good combination.
Thank you, sir. So Dr. Kalra, your take-home message, I think you have given so many messages today. So final message.
Single word, sir, that is togetherness and interdependence.
Yeah. Thank you. So, Dr. Akash, can you finally give the vote of thanks and conclude with your message?
It was, as usual, a very, very interesting session from Dr. Kalra. We have been hearing him so much on YouTube, so much in conferences, and it was a pleasure to hear him again this time. The references he gave to Vaishnav Devi, to the Mahabharata, all point to the fact that he is gradually becoming the Bhishma Pitama of diabetes, and definitely he is omnipresent as far as the diabetes is concerned. So I thank him profusely for such an excellent lecture. I thank Dr. K.P. Singh for moderating this session so well, and we also had the opportunity to hear very important views that he had. he shared on this platform, which definitely would benefit the massive audience that we have. I thank Dr. N.K Singh, Dr. Bijay Patni for being with us basically for this regular CME updates, which bring in so much information. I thank all the doctors who have attended this session because their attendance only is the encouragement for us and propels us to do a regular CME activity. I thank the USC team, entire team, for being so cooperative, and Dr. Snehal, Dr. Shweta for being with us basically to coordinate and monitor this CME show basically, which is becoming increasingly popular. Thank you very much. I
Yeah,
hand over
thank
the
you.
session to USV.
Yeah, Sweta, can you now wind up?
Yeah, thank you so much. Firstly, Dr. N.K Singh sir for this organizing this program, and Dr. Sanjay Kalra sir for being such a brilliant speaker and for giving touching the doctors through the references that he gives. It's absolutely a pleasure to always listen to him talk on various subjects on diabetes. And Dr. K.P. Singh sir for moderating the session, and Dr. Akash Singh sir and Dr. Bijay Patni sir for giving your valuable opinion. Thank you so much, sir. We can end the session, and I hope we continue doing more sessions on diabetes and the various aspects. Thank you so much.
Yeah, so I think good night to you all. Thank you very
Thank
much.
you. Thank you.